and I hope everybody had a chance to have a good break. I've seen some of you in the earlier meeting. To those who've joined us for this part one, welcome. Pleased to welcome Catherine, who's joining us today. Kath, do you want to just say hi and introduce yourself?
Hi, good afternoon, everybody. I know it says Catherine on my email. I'm very happy with Kath. Kath Smart, new non-executive director and audit chair, incoming. Yeah, great to meet you all. I've met Tony this morning online, so we've had a nice chat. So I look forward to meeting the rest of you.
Brilliant, great. Nice, good to have you with us, Kath. So let's get started. Looking at the number of people on the call, we look like we're quorate. Apologies for absence. I have from Sian Johnson, from John Arthur, from Dean Royals and Keith Nurkham, who are on leave. And I don't know if John has joined us because I know he had a conflict with another appointment, was going to try and make it. But if not, he's provided his apologies as well. Declarations of interest. Are there any matters on the agenda that colleagues would have to declare a conflict with? No, I can't see any there. And as usual, if you've got any updates to make to it, please get in touch with Katie in the board support units office. Go then to the meetings of the minutes held on the 16th of October 2025. Are there any corrections to those minutes? Looking down, I can't see any hands. No, thank you very much. Are there any matters arising from those minutes? Tony.
I apologise, just slight delay. Page 6, we had the obviously discussion about primary care services and the business transfer. We've just discussed it again as governors, and I think there are still some outstanding questions about what's actually happening. And I know we've had several conversations about this. I know it's the responsibility of the ICB, but governors are getting feedback from patients and members of the public about this, especially in the Bridlington area. And I don't know if is Kimberly on the call? Might want to. Kimberly's. Unfortunately, Kimberly's not on call and raises. Marilyn, did you want to speak about it? Because I know you've had some issues with Market Wheaton, haven't you?
Yeah, I'm just a bit concerned about how this is affecting staff, and because they're still obviously still don't know what's happening to them. And the other thing is that quite a few people have said to me, when is it going to happen? It's supposed to be happening. We don't know anything. And I sort of think, when is it going to happen? When will we know where we're going? It's not a very good position to be in, really, I don't think.
Okay. Michelle, would you like to sort of add anything, comment to, or some, if there's any more clarity than we've already provided to colleagues? I know it's a difficult time, and I know it's a difficult time for staff in particular, but assuring you that they are being kept informed as much as possible on all of this, and it's a top priority for us to make sure that this is done for the patients and staff, because it's still our responsibility until the transfer to ensure that we're providing good services. Michelle.
Yeah, thanks. It is always a difficult time, that transfer and that transaction in relationship to moving, but staff have been kept involved and informed, and the service managers are meeting regularly with the staff and the service managers. So I think we need to look at why we're still being said that we're not being kept informed, because that information now is going out to the staff as soon as we get it, really. Just these things do take a long time. Now, obviously there were some initial issues to start off with in relationship to the heads of terms, but we've got past those now. So we are geared up to continuing the transaction before the end of the financial year. Now, we know that that's not ideal because that's a long time, but these things do take time in relationship to, it's not just as easy as handing over a set of keys, for example. And I know that I'm not trying to make that it's really difficult to go through everything that we need to do. So all that is well in hand, and the exec team are following it really clearly. Lynn's on the call. I'm sure she wants to give you a little bit more of an overview, but we do get regular updates of the exec team, and I think it's a lot more than that as well. But we are communicating as fully as we can with the staff, and we're working closely with the ICB as well. Patients, they should be communicated as the practice, because the practice are the people that know how best to communicate with patients as well. They know a lot better than we do. But I don't know if there's anything further you want to add, Lynn.
No, I think just to reiterate what you have said, Michelle, there is a full project overview, including myself as the SRO for this programme. I get weekly updates. A big part of that is how we're communicating with our staff. So we are absolutely communicating everything as quickly as we possibly can. There are regular meetings in place. The practice managers are very much part of those conversations. And we are now starting the full 2P transfer process, which does include consultation and communication, obviously, with our staff. It is a difficult time. We absolutely recognise that. And we are offering our staff support through that time as well. Our HR colleagues are fully engaged with the process as well. So I will check in again this week, as I always do. If there's anything more that we can do, we will do, but we are communicating very, very regularly.
Thank you for that. Ted.
Yeah, I mean, I've been down to the surgery several times recently, and the staff down there tell me that they know nothing at all. The only thing that they know is that it's not going to happen this financial year.
Well, they've been given more information than that, Ted, so that's all we can say. We know what information we sent out to staff, Ted.
Look, Tony, I won't make a comment, so I hope you've all said something. Tony.
I think Kimberly's just joined the call. Well, she was on the call. She's gone again. My understanding is that, I know from the Bridlington practices, that the concerns being raised is the fact there will only be one provider, you know, covering these practices around it. And
Go on, Tony, but we've talked about this several times before, Tony, that is not, that was always the case in relationship to Bridlington. That's been the case for the last few years, actually, because we've already amalgamated some of the practices that are up there. There used to be other providers of primary care services at Bridlington. If you remember, about 18 months, 2 years ago, we amalgamated and merged services then, because the whole idea was to get to one, and that's in keeping with PCNs, it's in keeping with neighbourhoods, it's in keeping with the 10-year plan and the left shift into community. So again, that's something to take up with the ICB, but we're only working to that strategic footprint that we have known about for a long time and we have discussed. And I know it's difficult, and I know it's difficult for patients, which is why we actually kept two for a while, because we didn't want to go straight into one. So if you remember the time when there was some other amalgamations and mergers within the primary care up at Bridlington, we actually, as an organisation, said that we thought it would be better to keep two practices for a reasonable length of time to see how that adjusted. So I empathise, but that is, as I say, the strategic footprint.
So I think for governors, is there any advice, please, Michelle, on what methods or avenues they could use, you know, to communicate their concerns or issues that they have?
What, from a governor point of view, or
from a governor point of view? Yeah. I
mean, I think you can have them write to myself, or you can write to Lynn, I think, in the first instance, or we can, if it's to give out to staff, the staff need to contact their relevant line manager and their relevant processes, to be fair, Tony.
Okay.
Is that helpful?
Yeah, thank you for that. Okay. Thank you.
Thanks,
Marilyn. Marilyn, you're on mute.
Thought I'd take myself off. I couldn't quite hear what Ted said, but I mean, I'm chair of the PPG at Market Wheaton, and I've heard absolutely nothing for weeks and weeks and weeks. So it looks a bit like the PPG is not being involved in any of this, which I'm quite surprised at, because the PPG at Market Week is quite an active PPG. I know sometimes we can be a pain, but even so, we are quite active. And it would have been nice if we'd been involved with what was going on. I know you can't, I know it's difficult because there's lots of stuff you can't talk about, but I think Market Wheaton are particularly concerned because it doesn't seem like, if we're going to this particular place, that they have a particularly active patient group. And so I guess there are a few people worried that that might be a problem. But I'm just saying, I think it would have been nice had the patient group been involved in what was going on, or more involved in what was going on.
We can get some more information, Marilyn. We'll get.
Oh, there's a bit of an echo.
Well, we can get you some more information, Marilyn, in relationship to the PPG. What the receiving practices are doing in relationship to their PPGs for the PPGs to sort out actually at that time. But we'll get you some information.
Okay, thank you for the comments raised and feedback that colleagues have given. I think obviously Michelle has outlined, but for Lynn, I think as the SRO is to check in, given the comments that governors have made, which they're feeding back, as to making sure that information is being. I know information is being sent out, but I think just make sure it's really embedded, that people can, if they don't feel they've got the information, particularly our staff at this time, that they, do speak to their line manager, and if they're not getting through that way, go escalate it higher if need be. But we don't want, as much as is possible in this, situation, all information that is available should be available, and we wouldn't want anyone to be without that. And I think, we absolutely appreciate that. So Lynn, if you could take that away, and just to make sure we've covered everything, belt and braces, I think that'd be really helpful. Thank you. Thanks, governors, for that. Any other matters arising from those minutes? No, I can't see any other hands up for that. Can we approve the minutes of the meeting held on the 16th of October? Yeah, great, thank you very much. We've also got with us for this meeting the minutes of the annual members meeting held in September. And just governors who were there, obviously, is there anything in these minutes that stand out? Obviously, they will go to the AGM, the annual members meeting next year, but is there anything we want to flag now, given that in 12 months it'll be a long time after? No? Okay, that's great. Thank you for that. Anything on the action log or work plan? No. Okay, thank you very much indeed. Now we have our spotlight on the service, and today it is our child and adolescent mental health pathway and Thrive approach. And I'm pleased to say we've got Justine with us today. Justine, have you got a colleague with you today as well?
I have, Caroline, thank you. I've brought two today.
Great.
The people key to the operational changes in the pathway work. So shall I introduce myself and then allow them to? I think everybody. I have been a couple of times to this meeting, so I think you have met me before. But my name is Justine Rook. I'm General Manager for Children's and Learning Disability Services within the division. And pleased to introduce Nikki.
Hi, I'm Vicky Titchener. I'm the Service Manager for Plan CAMS, which is the core CAMS services across Holland East Riding, LAC CAMS and Contact Point as well.
And then also Karen Warwick.
Hi, yeah, I'm Karen. I am the Service Manager for what we call the Acute CAMS Pathway and Eating Disorder Service. That includes Inspire Inpatient, CAMS Crisis and Intensive Home Treatment, and Eating Disorder Services, including Eating Disorder Intensive Services. Pleased to meet you all.
Thanks, everybody. Shall I go ahead, Caroline, and just set it? Okay, thank you, everybody. Do have a slide. Some slides that we're going to share. How long, Caroline, have we got? Would you say 20 minutes with questions, or?
20 minutes with including questions, please. Thank you. So about 50-50 split, if that's possible.
Yeah, sure.
Thank you.
I will just share the screens. Okay, go to slide share beginning. Just tell me everybody can see this one. So yeah, so yes, thank you. So just to remind everybody about where we were and why we started this work off. This slide highlights that, and do shout up if you can't see these slides, because as we're on Teams, can't always see everybody. Do you remember back in April we came along and we were talking about how disjointed some of our CAMHS pathways had become? And that was due to the fact that a lot of services had increased over time by stealth and had been bolted on because it had happened through a sense of necessity just to be able to bring some of the services in, particularly around those crisis areas and those early intervention services. So when we presented a pathway, I think it might have been Michelle and Lynn who said to us, but Justine, it looks really difficult to navigate, you know, and actually what we were seeing at the time as well were complaints coming in from families that were expressing that same problem, that they didn't know how to navigate our services and it felt disjointed. So we set off on this piece of work with really clear objectives, which are in the bullet points aside. So that was just to streamline our clinical pathways. But whilst we were doing that, making sure flow between service areas was really seamless and there was not gaps or duplication in those areas. Also on top of that was a real desire to drive down waiting lists and really improve access. And I'll talk about some of those issues through the presentation because they're really key to the embedding and implementing of the long-term plan and the medium-term plans that we have as well from NHS England. A big part of this work as well was also to really review and look at what we were doing within our routine core services. So Nikki's going to talk to you about the progress of something called the CLEAR project, which stands for clinically led. Nikki will explain exactly what CLEAR stands for, but it's clinically led project. I can't remember the E and the A and the R, but I know Nikki will. So, and then also Karen will talk a little bit about how we've developed our Nova space as well, and the new service specification that's come through. So just going back now then to the original point as well, which was around the Thrive framework. So the Thrive framework is a needs-led framework that children, young people, families should be able to step in, step out of, and it should feel seamless to them as well. So although it does revolve around need, it also does revolve around risk. And as we know, families are dynamic, and 1 minute they can be seemingly doing real well in the community. Something will happen in their lives and they suddenly find themselves needing risk support or needing some real intensive support from CAMHS. So it's very dynamic. And that was also some of the work that we've looked at through our pathway about how we manage that. And Karen's going to talk a little bit about that, about risk management through the different services. So that was just a reminder of Thrive. So the initial presentation slide that I showed you, it had lots of services that looked like they were bolted on. This is a current model that we're working to now. So you'll see the pink areas, they're the areas that are really outward facing. Most of those, well, all of those services are based in the community centres where children, young people, families go. Quite often it's education settings, it's youth centres, it's homes. So there are services that we're managing, but they're very much rooted out in communities, and that's where most of those interventions happen. Coming over into the blue slide, you'll see they're more our specialist services where interventions are very much rooted and health-led. There is a social context around why those children are needing CAMHS support as well, but quite often it's become more intense, so it can't just be managed out in the communities. They need to come in as some of our specialist services. But you can see how we've worked to make that as a one-team approach. So referrals come in where before there'd been some disjointedness around who sees that child, and you've got different professionals who think differently. We've joined that all up and provided the infrastructure and the mechanisms so that if there's any dispute or if there's any people who are unsure, it'll go through to something called a one-team multidisciplinary team meeting where the needs are assessed by a team, and then the flow for the young person goes to the right place. And also what we've done as part of that is to really embed in our key worker model as well, which looks at a named practitioner to be able to navigate with that family young person around services or around different parts of our pathways if they do need to switch them. I put the key worker service as well there. That's a key service that helps children who might have a learning disability or autism as well. It's an extra support session that they can have as part of that pathway, because we do know those children are high risk support, need a lot of risk support, but quite often don't need to come into inpatient units, quite often where they can end up if we don't intervene early. So just one of the main functions we said was around improving access, reducing waiting lists. So the key services to that is our mental health support teams. So these are the new services that sit very much within that pink area. So they're delivered out in schools, they're in youth centres. There's three main functions of the mental health support teams. One of them is worked at one-to-one support that a family can have if that child is referred in to schools by a teacher. The other is what you call the whole school approach. And that is really how those teams sit within schools and really support schools and teachers and education settings to manage low to moderate level issues that a child might face within their emotional, mental health well-being. So for instance, if families have, they're going through some divorce, or if children split up from relationships, as soon as that anxiety or any issues start to occur, that child and family can access support really quickly through these mental health support teams, and also get the same approach embedded across from teachers, pastoral support, all of this. That support will be provided for them in their communities. The final function for that is what we call the getting it right first time. So that's just helping those families and children navigate the systems that we've got in place, look at additional support, and where they do need these more specialist services that Karen and Nikki will talk about can be fast-tracked in, so that their needs can be met quite quickly. So one of the main functions for some of this is to provide that low to moderate support, but really to start to look at how we can get children into the right places at the right time to avoid any kind of waiting list pressures in the specialist services, and to increase access. So visibility is really key to these services too. So families, children, young people, they know where to go for help. I'm going to talk a little bit about how we're changing some of these services with the strategic alignment later on, because there's a big factor in there around GPs and the current processes that we've got. But I've put it into this is the work that we're still doing as we move through the pathway transformation. Okay, I'm going to, at that point, just bring Nikki in to just talk an update about the CLEAR project. Are you there, Nikki?
Sorry, apologies. So CLEAR, it stands for Clinically Led Workforce and Activity Redesign. And what CLEAR is meant to do is it brings clinicians in, that places them at the heart of healthcare decision making and innovation, and combines clinical insight and data analysis to create innovative new models of care and workforce redesign. So that was my job a year or so ago when I was seconded into the CLEAR piece of work to look at core CAMHS as a whole and try and redesign what we were doing as a service. And what you can see in front of you on this slide is the new model that was developed that came out of CLEAR. There was lots of things that came out of CLEAR as well. There was lots of recommendations, but this was the main piece of work in terms of the model. And I could talk to you for a whole session on CLEAR, but we'll because there was so much that came out of it. The main things that I'd like to point out today is the family partnership bit, which is the green bit in the middle, because it's made such a huge difference to the young people that we're seeing at the minute. So instead of young people coming in and having to sit on waiting list after waiting list when they're going through the system, what's happening is they're coming in, they're getting picked up by the clinician that's seeing them, not just for an assessment, they're seen as a whole family, because that's what we felt was missing. Young people were coming in and they were being dealt with as individuals, and that didn't feel right. So now they get an appointment with a clinician and their whole family, and they have the option of being seen for up to 6 weeks with their family. So it's making it much more of a systemic way of working, which should always have been the case. So they can have 1 to 6 sessions in that initial piece of work, and the results from that are really quite phenomenal. So the normal way that we used to work, 56% of young people would go through for additional treatments, whether that was family therapy or CBT or through to medics. We're only getting 28% of young people going through for that additional treatment at the minute with the family partnership way of working. So that's proven really to be working well. The other thing that we're moving on to as we're developing the model through is that the people that will be doing the family partnership way of working will remain with the young people and family throughout their whole journey through core CAMHS. And this was one thing that came up with the young people when we were consulting with them. And I think that's something that's been really important throughout the whole of this project is co-production was really, really important. And all the projects, little projects that we've done throughout this is the young people have always been consulted with. So they told us that we're fed up being passed from pillar to post and having this clinician and that clinician. So we're having their family partnership clinician that they will work with them throughout the whole journey. So even if they go on to a new therapist after their family partnership, that same clinician will still remain with them so that they can help with transfers, with information at any point. So we're hoping that that's going to prove really helpful to them. Obviously, in terms of that as well, we feed into the one team MDT if we need to for referrals to go either back down or further up into the intensive teams. So that's also working really well for us as well. And so what I'll do now is I'll pass on to Karen and let her tell you a bit more about the intensive services.
Thanks, Nikki. So this is the Getting Risk Support. So we in Humber we call it the Humber Acute CAMHS Pathway. It's our Getting Risk Support services, and they've really been designed to provide the least restrictive care for children and young people, avoiding unnecessary inpatient admissions wherever possible. This soon would evolve into what the NHS England is calling the Children and Young People's Intensive Mental Health Service. So aligning with this new exciting NHS England developmental specification that is changing how inpatient day services that are being introduced, crisis home treatment services and alternatives to admission services. And their focus, as you can see from here, which is something that we've always tried to do, is look at early intervention, timely intervention and smooth transitions. As always, as across the whole of CAMHS, we're using trauma-informed practice underpinned by the ARC framework and AMBIT principles, which is around supporting the system around a young person and their family to ensure that care is responsive. It's not about new structures, it's about strengthening what we already do, working collaboratively with the CAMHS Getting More Help, CAMHS worker, whether that's core CAMHS or eating disorder service, to deliver care as close to home as possible, which is obviously what young people and families are always telling us that they need. We've really embraced the NHS England's vision for a flexible workforce without realising it. We've been ahead of the curve. Over the past 3 years, we've grown our own staff, embedded joint training and promoted reflective practice. And this means now that our workforce can flex across the pathways, ensuring continuity and resilience. And we're really pleased to say that we're in a good position to be early adopters of the model that NHS England has promoted, as we've always been really forward thinking in our approach to alternatives to admission. In fact, earlier in last year, NHS England actually visited us as one of only a few handful of providers to give it feedback on the addendums that they're creating as part of this new specification. So we were really able to give our feedback on that. And the new Inspire Family Day Service, which is what the Novus redesign is about, is fantastic. We've successfully, get my teeth back in, successfully secured funding for launching in spring. It's a prime example of innovation that we'd already been working on. The Family Day Service is being developed with co-production involvement, children, young people and families. They've been really key to the development of this, providing an intensive family-focused alternative to admission, reducing out-of-area placements and strengthening integration across services. Can we have the next slide, please? Yeah, so this is our success, I think, lies in working as one team across the CAMS workforce. This image was used as part of the day service business case that shows how all the teams work collaboratively as one pathway to manage risk when supporting our most challenging and complex young people and families. And Nikki and I lead different parts of the CAMS service, but we operate as one system and pathway, meeting weekly alongside Vicky and Sean, our senior clinical leads, to promote this. And then through the one team operational meetings that have been recently set up, that Nikki and I alternately chair, to the team leader forums, to the fortnightly integrated pathway meetings for complex cases, we ensure that CAMS is one pathway that works together and flexes to meet need. And just one very small example of this work that we've done since we've had the integrated pathway meetings is we have an advanced clinical practitioner in our intensive home treatment team who has recently taken on a lead role for a young person with a life-limiting condition that was being offered art therapy within Core CAMS. And with her expertise in supporting from a physical aspect, we were able to put the family and the young person at the centre of everything we do and ensure that we provided a bespoke intervention for very exceptional circumstances. So that's me. Thank you.
Thanks, Karen. So just the final part of the transformation was the underpinning clinical models that run alongside this. So you can see the two there, there's AMBIT and ARC, you'll have heard of those no doubt. And they are embedded through supervision channels, through sharing of assessment and formulation documents that are being devised as well as part of this work. And overall, there's an overarching trauma-informed care methodology that's used across all of our CAMS services. The next slide, I know there's lots of writing, so I'll just pick out some of the issues then that we maybe haven't brought up just with time running on. So you can see, just pick out some highlights. Contact Point, which had been a standalone referral in point, has now been realigned into mental health support teams in our specialist areas. You've heard Karen and Nikki talk about the one team approach, MDTs, which is building in the infrastructure and the mechanisms to make sure that the flow is right and that the services are operating as one team. Nikki talked about CLEAR, and then there's the neuro inclusion training, which came to us really on the back of young people telling us that that's what they wanted. I mean, we knew there was a drive and we were going to be embedding that in as well, but it's real good to hear those young people particularly picking that out. An example of that is adapted. It's called cognitive behaviour therapy. That's also being used within our mental health support teams, specifically due to the rise in neurodiversity that we're seeing. Secondly, access we've talked about, and the engagement with the Humber Youth Action Group. The dynamic support register and the importance of the key workers through this pathway. And we're really lucky to host those at Humber as well. They work across the whole ICB, but we have a lot of opportunity to influence and to embed them within our services because we host them at Humber. They play a particularly key role, as I mentioned earlier, in the admissions avoidance for our LD and autism communities. We've had a lot of work and success with our medical staff working together. Nikki mentioned the key worker model, which is that implicit role that helps that young person and family navigate across those services and stays with them as the point of contact. And Karen mentioned our shared clinical and operational meetings. So that brings us to an end of the changes that we are planning to make through our transformation. So now we're moving on, and we've had the benefit of being able to have 8 months, 9 months working on these projects. So the quantitative outcomes that we are managing and collecting are the ones that are listed on there, and they show the areas where we're expecting to see the improvement in performance, productivity or quality. We manage a lot of these as well day to day. So we're doing a lot of work with our clinicians around the importance of those quantitative outcomes. For instance, KPIs at 18 weeks. It's a real key measurement of a child and how long they're waiting for a specialist service in terms of how their mental health and well-being is managing whilst they wait. And if they go over 18 weeks, then we know that there's going to be an impact to that child and family. Where we have got some of our long waits, what we have done, it's not necessarily part of the pathway work, but it's come out of some of the discussions with young people and our service managers around how we manage it. is we use Mind to support with our waiting list as well. So they regularly, the staff that come in and regularly check in now with our families who are waiting over 18 weeks, so that we can be a point of contact and just see how things are going for the families whilst they wait. And within that, we can escalate risk, or it can move up into one of our more risks associated services if need be. Also a lot of qualitative evaluations as well. So we're talking to the young people, and it is really heartening what they tell us, really. And some of the things that you think you would know, when you hear from them, you think, of course, they make it seem so simple and easy to understand. So for instance, they'll say to us things like, it's really important you see us quickly, because if we feel like we're sat on waiting lists, we feel like we're not, worthy. And that's something that really sticks in your heart, doesn't it, when you hear stories like that from young people. But what we're doing is feeding all of these discussions and these insights that the young people are giving us, so that we can make sure it's 100% right for them, because they're their services. So I won't dwell on this. I'm just going to, getting short on time, just talk about how
long are you going to be?
Last one, Caroline, this one, last slide.
Thanks.
Strategic alignment, then it's just how, can you see the two triangles? The triangle on its head is where we are now. Triangle on the right way up is where we need to be. And that's that. I've talked to you about the mental health support teams really widening up that access, so we can get that early intervention right, which just sits really with our transformation plans from the ICB and the long-term plan and medium planning guidance as well. So I will stop there, Caroline.
All right. Okay. Thank you very much, Justine, Nikki and Karen. Any questions? I've got one in the chat box from Kimberly. How could other, voluntary and community groups receive some of the training you outlined? And then I've got Emma after that. Justine?
Oh, sorry, the training outlined. The ARC and the AMBIT training, Caroline.
Kimberly, do you want to clarify?
In the chat, sorry.
Hi, yes, sorry. It was some of the different training that you offer, and the autism training like that. You sort of mentioned Humber Youth Action, a champion at the moment.
Anybody want to pick that up?
I don't know if
I was frozen, hadn't I? So yeah, how could you? We're really keen to work with all voluntary sectors. We do a lot actually in our neurodiversity services with Matthews Hub. Just be keen to link in with anybody.
Okay, sorry, Justine, you're frozen.
I have, and I can see. Yeah, Nikki or Karen, step in if that happens again. It's one of those things.
We certainly, I guess what we can say is we certainly can have conversations with people about how we could involve that. Yeah, definitely.
I suppose. Okay, I'll bring in the others. I suppose there's a thing around just how, for example, schools, other voluntary organisations, groups are involved in the planning of this service, and their input as well. So they can clearly they've got such an important role to play in all of this as well.
Yeah.
Let's go to Emma, and it might come out in some more questions. Emma, and then Ted, and then Tim.
Well, Caroline, what you just said was going to be part of my point. So I think really good presentation, and obviously there's a lot of work being done, and I know about some of it. But I think listening, it feels like my question was going to be around the voluntary sector, and the voluntary sector didn't get mentioned until the very end around us doing some of the waiting list work. And it kind of feels like it's become more insular rather than looking out so much and really utilising the skills of the voluntary sector. It feels like more work is being done by the trust rather than seeing what other skills are out there, because many of us, and I absolutely include Mind in this, are professionals, and we can deliver mental health services to young people, and it feels like that's reducing rather than increasing.
Oh, okay, we can have a look at that. I'm sorry to hear that. I feel like with our mental health support teams being particularly outward facing, we've been doing lots of work across the different sectors so that doesn't happen. I was just putting in the chat as well, because my teams did drop off a little bit, so it was disjointed, that we make sure we always attend all the Thrive boards. specifically for that. So all of our transfer, we've shared these presentations at the Thrive boards to make sure we've got that inclusion.
Yeah, no, Justine, I get that, and I agree. I absolutely agree. I think the outward facing bit is different to utilising the voluntary sector.
Yeah, is that well? We've got well, maybe we could have a conversation then after. With our safe space work and then our waiting list support, we were feeling, you know, the work we do in Matthews Hub, we feel we do a lot of work. But if it doesn't feel like that,
and I'm working with Barnardo's at the minute as well. So
sorry to sort of interject there. So one of my other roles is I'm help support a youth charity in Bridlington, and we're finding that the engagement with charity such as us do a lot of youth lobbying. Been no engagement with us, and we have a lot of young voices who very powerful voices that could lead into this, who don't feel like, you know, they get the support that they need. And I think something with Bridlington, it is forgotten quite a lot. So anything that could be done in regards to working with some of the charities there, such as Fuse and Mind and things like that, to look at those young people affected in Bridlington.
No. Kimberly and Emma, we would absolutely love to do that. I mean, there's certainly nothing from our point of view that makes us want to be exclusive. We really do want to work, more collaboratively.
I think also ensuring that voices of all children and young people are taken into account in this, not just those who are Hull based, but you know, those that are East Riding based and predominantly Bridlington as well, which is it's forgotten. It's a spoke.
Yeah, we did do some work with Bridlington. Bethy picked that up with.
Can I just take a few more questions? I think the thing is, I mean, I know the Humber Youth Action Group does some great work, but they're only a section of kids from across the area. Some young people and children might be involved in other things as well. So I suppose that's part of the thing, that the message that governments are saying. There's services out there that could help actually with delivery, as well as just obviously being signposting. And there are lots of other young people and children out there who could, you know, benefit from their engagement. Maybe that's something to take away. Let's carry on with some questions. Ted, and then Tim.
Yeah, thanks very much. First thing I want to say is this is a really, really impressive piece of work. I mean, it ticks all the boxes: concentration on the patients, joined up thinking, continuity of care, which I think is very important. And what my question is about is how can we capture all of these learnings and then apply these learnings to other areas? Medical areas, not only the infant. I mean, all the it's just, so can you capture what you're doing, prove that it is actually very effective, and then try and get other people in other areas to do the same thing? Because if it's now been coordinated by NHS England, I mean, my understanding is that it no longer exists. But anyway, a really, really impressive piece of work.
I think I'd have to skip those final slides. They didn't go into as much detail as I wanted, but I think you're right, Tim, and I think there is that overarching. The long-term plan spells it out, doesn't it? It's, you know, treatment to prevention, which is the shift we're making. It's hospital to community. Although, you know, cancer is not necessarily hospital, it's that intensive treatment. But what we're trying to do is encourage more and open, make it much more accessible for families to be able to seek help early in schools and in their own communities. And then the other one's the analog to digital, isn't it? Which we're using. But I think those shared, if you stick to those shared themes, the learning can be applied to all areas. And
the one that I particularly like is this continuity of care, because I think continuity of care is really important. And I know it's difficult to do in the other places in the NHS, but I mean, it would deliver us enormous benefits. But my hobby horse.
Thank you, Ted. Tim.
Yeah, thank you as well for the presentation, but I hope you'll forgive me. I want to ask something different to do with one of the specialist services, because it comes up as mentioned later in our agenda, and that is the eating disorder side. With the closure of the Shone Clinic in York, where now, because that was already out of area, but a necessary facility, where now are people having to be referred to, please?
I might defer to Karen and Nikki for that one.
But so the Shone Clinic is for adult services. Were you meaning adult services, Tim? Or
And
were you
I'm talking about
talking
eating disorder, the Shone Clinic in York.
Yeah, so the Shone, it's for adult patients. It's not for children, young people. I can tell you about children, young people, but I unfortunately can't talk to you about adults.
Can we just stick to the children side of it?
Fine, okay,
I
I'll
know
leave
that
it.
obviously
Leave it at that. It came up later in the agenda. Thanks a lot.
Obviously Inspire, you know, we have facilities there for children and young people for whom eating disorders are a factor in their treatment, their programme. And of course, I think that is also linked, correct me if I'm wrong, operational colleagues, that we're providing a home-based service as well, which I think includes those children and young people. Am I right about that?
You are absolutely. So we have a very good inspiring patient unit that supports young people with eating disorders. But as I said in the presentation, we're looking at least restrictive options. So one of the things that we've been very lucky to have been commissioned for is an intensive home treatment team specifically for eating disorders called EDIT, that's been running for the last 3 years, and it has really successfully prevented young people, a lot of young people, in needing a hospital admission. We were inundated over 3 years ago on young people that required inpatient admission, whether that be in an acute hospital paediatric setting or in a CAMHS inpatient setting, and we've really successfully reduced that in having that intensive home treatment team. So really showing really positive dividends in keeping young people closer to home and within their communities.
Thanks. If we'll come back to the adult later, if that's all right, under another item, Tim, if that's okay. I can't see any more hands up. Anybody else like question? Can I just ask quickly about where are we on the children's facility being on the Inspire site? I understand the service that is at the Mind Building, which I visited not so long ago and saw the most adult and children's provision there. Plans have been underway for some time to get the children's service with Mind involved in that run out of our community, you know, the open community building that we've got on that site. Where are we on that?
Is that the safe space, Caroline?
Yeah, safe space. Thank you for giving me the right
we've got
there.
plans.
Sorry.
Yeah, we do have plans. We're just working those up, and we're looking at some estates work as well, which is due to start in February across the Children's Centre at Walker Street, which will enable some of those changes.
Okay, how long's the projected schedule for those works?
Do you know changes, Karen?
So yes, so it's towards the springtime. So work will start beginning in February, and yeah, will be springtime. Yeah.
Okay, I think that's a good partnership. Like obviously, it'd be good to see that come to fruition. Okay, fine, thank you. So I think honestly, I think the Thrive concept, everyone in the comments, it's a really good one, really, really positive, and thank you for all that. I mean, it's been. And again, I mean, there's a number of trusts taking up the Thrive model now, aren't there? As I put in the chat box, I think it started by the Tavistock and with the Anna Freud National Centre as well. I think maybe just a takeaway is about some more about just that involvement of the voluntary sector, and schools are part of this as well. I think in Camden, every single school has signed up to be part of the sort of the programme as well. So I think that'd be a really positive. You've got people on this call who are really willing to have those conversations. So thank you so much for that presentation. And if you could take that away, Justine, Nikki, and
thank you,
Karen, that'd be super.
Will do.
Thank you. Thank you. Please show your appreciation, everybody, virtually. Thank you. Brilliant. Okay, we'll move on now to my report. I'm not going to go through it. I just want to pick up on a couple of things. Congratulations to Ted, who was re-elected as our governor for the rest of England. We're going to change that title to the universe at some point, but anyway, no, we won't. We won't be doing that. But congratulations, Tim.
You just said Ted, not Tim.
Oh, Tim. Sorry, Tim. Ted can be, I don't know, global ambassador or something like that. Anyway, so Tim, congratulations. We still have a vacancy for Hull, sadly, and also just to say our thanks and best wishes to Simon Blackburn, who stood down from being a governor just before Christmas, and I know maybe some of you are in contact with him, so send him our regards and thanks for his service. I've already mentioned about Kath joining us this week, and this is Stuart's with us, I think, this is Stuart's last Council of Governor meeting before he leaves at the end of the month, and I'm sure we want to wish him well, and Dean as well, who's leaving too. But yeah, Stuart, thank you very much for your service for the trust. The next, thanks for everybody who, including actually Simon, who has given us some really good subjects to plan the schedule for governor briefings and the governor development sessions. The next governor briefing at the end of this month, 29th of January, is actually going to be on the long-term plan to update governors of what's happening in that particular space. And the only other thing I just wanted to raise, which isn't in my report because we've been waiting on news from the Parliament, is the annual report has now been laid before Parliament. We were hoping this would happen so we could have this on the agenda for this meeting with a presentation on the accounts as well and the external audit. That was unfortunately not able to happen because of having to wait for the parliamentary part of that process. So we will be looking to have a special, if you like, COG just on that item in the not too distant future, so we can make sure that whilst that's still live, that you're able to hear from our external auditors. I think it is Pete, correct me if I'm wrong, who will come along and give their viewpoint on the accounts, but also hear any questions from yourselves. Are there any questions to anything I've said so far, or anything else in my chair's report or comments? Tony.
Caroline, just to concur what you said, and on behalf of the governors, we want to thank everyone who's leaving us or moving on or whatever they're doing. So many thanks from all of us for that. And just a query from one of the governors in terms of for a governor who is leaving, is there an exit interview process? I wasn't sure about the answer to that, if I'm honest.
I think it might be happy to. This sort of happened just in the run up to Christmas, so yeah, I'll double check on that. But I'm happy to do that and be. I have written to Simon, and yeah, happy to do that. Yeah,
thank you.
Anything else? No, thank you very much. We'll move on to Michelle, the Chief Exec's report.
Yeah, thanks, Chair. Obviously, people have a chance to have a read of it. There's a couple of additions that I'll come through, but hopefully, obviously, we can ask any questions. Pete and Lynn are here, and we'll pick up the finance later. So obviously there's been a lot of movements around the system in relationship to appointments, which are included in the report, York and Scarborough Hospital, for example, Humber Health Partnership, etc. And in fact, the substantive chair role is actually out now for the chair of Humber Health Partnerships. Claire has been with us now for a while, Claire Smith from York and Scarborough. I met with Claire a couple of times in getting established into that post. It's pleasing to know that Teresa Fennick was appointed the substantive chief executive of the ICB, our ICB. Teresa, it was the director of nursing. She was in an acting capacity since April, since she came back from New Zealand. So it's good that we've got some stability there. Lots of things happening at the local authority, which you'll see alongside the Quality Commission report there, reflecting the local authority, and we're working with all our local authorities in relationship to their reports. I mentioned a little bit about the mid-year reviews. We weren't asked to go to a mid-year review this time, which is really positive, and that was due to our segmentation level. But we did have a meeting on Monday with the team, which we'll go through at a later meeting, and we'll just absorb that and wait for the letter in relationship to our first cut of our planning guidance, which Pete will touch on later. I mentioned in my report about the merger of the NHS Confederation and providers. That has happened, and we're still working through that transition process at the moment. Lynn will pick up a little bit around the winter pressures, but I'm pleased to know that our plans, and I will say this out loud, are being substantiated and are working well. And we've had some very bad weather. We've had storms, we've had snow, we've had the resident doctor strike, but thanks to Lynn and the team, our staff have come really well. And we've been at a fairly steady OPAL level, which Lynn will take up. There is a little bit in the report where I'll draw your attention to about the ADHD task force. We were aware of that report coming in, and we are doing and looking at all the recommendations and are actually sort of ahead of some of those at the moment. Interesting to be aware of the professional strategy that's developing. This will be an enabling strategy for our overarching strategy. If you remember, we've just got the one strategy, which is our trust one, and underneath that we have all the enabling strategies. Well, we needed a refresh of our strategies, so we're bringing all the clinical services together in professional groups to have a professional strategy, which I think will be really, really helpful. The staff survey, we got a higher response than ever before. We have got the first cut of that. It is embargoed. We will share when we've really fully analysed all the data. That's just been analysed internally at the moment. It looks a relatively stable position at this stage. Flu, I am happy to say that we are third nationally at the moment for our flu vaccinations at 65%. In fact, we are catching up to Harrogate, who are the top at the moment with 66%. And we'll continue to vaccinate our staff in relationship to flu. Figures may stay still low, but we are doing well in relationship to the rest of the NHS. One of the areas that the executive team are focusing on is sickness and absence. We continue to have hotspots for high levels of sickness and absence, and I thank my non-exec colleagues for their appreciative challenge in relationship to sickness, which is always helpful, and the People's Committee will be overseeing some of that work that we are doing. There's a lot of focused effort on sickness and health and wellbeing, because as you know, we do a lot about health and wellbeing in the organisation. So we're just reviewing what we do and what we offer in relationship to our sickness figures. Sarah Rockcliffe was appointed the Substantial Assistant Director of Psychological Professions, and I raise that because it's all the psychological professions, so we're bringing all those psychological approaches together, which I think again will be really beneficial going forward. Planning, we're really in the middle of planning, so please bear with the executives. We are absolutely inundated with requests at the moment and have to do almost a weekly submission for a plan that we are still developing at the moment with quite limited guidance. So we're working through that at the moment. Pete will pick up a little bit of that in his report. The only thing to say is that the Mental Health Act 2025 has now received royal assent. It's not in my report because it came in after the report had gone. There's a 10-year implementation plan. I know 10 years is a long time, but we have got a detailed paper going to the board, which will circulate the next COG in relationship to how we are working through that. And obviously there'll be a load of implementation details that will come out. There is a first date, which is February the 17th, which we're on with this. We don't think it will affect us. This is not Court of Appeal, not I'm going to the Court of Appeal for judgments necessarily on deprivation of liberty with discharges. So that we don't think will have too much of an effect, and we have spoken to the local authority as well, but we are all over that. So we'll keep you informed as we go through in relationship to that major enactment. It's been on the cards a long time, about 15 years, so at least we've now got some decisive way forward on that. So there's lots in my report. There's a detailed charity update as well, and we delivered a lot of Christmas presents over the Christmas period. So I thank everybody that was supportive. I know some governors did support that process, which was great. Went down exceptionally well with our patients and service users, and we did have quite a lot of sing-alongs in relationship to our carol service throughout the organisation, of which I mimed very well. Apparently, you have heard me singing. You will know why I needed to mime. But they went down exceptionally well, and we did individual services across the patch rather than it just being central to the HQ, given our geographical base. Lots of things happening this year, which I will summarise in my report next time, because we're just finalising the dates for everything that we've got planned this year. And as usual, I'll be starting to ask people what they want me to do for my challenge. So I'll take a pause there. I'll hand over to Lynn just to give us a brief update on the winter planning and the resident doctors strike. And I'll leave Pete, if that's okay, Chair, unless there's any specific questions, because I know that Pete will probably pick up any questions later on in the agenda, if that's okay.
Thanks, Michelle. So as Michelle said, we are obviously in the midst of the winter period still. We've implemented our winter plan. I'm probably slightly more cautious than Michelle that it is just January still, and January can actually be for the whole system quite a difficult time in terms of sort of past variation. However, as Michelle says, we are pleased with the progress of our plan to date. We have managed those 2 periods of resident doctor action and the adverse weather in North Yorkshire, which was quite tricky to say the very least. We did have some quite heroic staff sort of walking quite long distances to work through sort of snow and road closures at that time. So I really do want to thank our staff in North Yorkshire who really did keep our services going, given that adverse weather, with no disruption or very, very minimal disruption to our services. So we have seen some sort of patterns around winter viruses as well. You'll recall that I've talked about that here before. The prevalence of winter viruses was significant last year in those system pressures, causing sort of those ambulance long wait times at acute hospitals, etc. Due to the combination of prevalence, people needing to go to ED or attending EDs because of those viruses, but also leading to high levels of staff sickness absence. So our flu campaign this year obviously was very much part of our overall campaign anyway, but very much part of our winter plan. And I'm really pleased to say we are, as I understand it, second in the league table across trusts at the moment for our uptake of flu vaccine, which is brilliant, I have to say. Before Christmas, we were seeing some spikes in absences in our staff due to winter viruses. So we had already planned for increased use compared to last year of flexible staffing. So those plans really worked in our favour as well. So again, we didn't see disruption to our services as a consequence of that. So in terms of those sort of OPAL pressures that I've talked about here before, our mental health services have been sort of OPAL 3. And our community services between OPAL 2 and 3. Actually, I'm really pleased to say, as I sit here today, both of those services are at OPAL 2. So those moderate pressures. So it really does suggest, you know, we are managing those service demands, and we are seeing some increased demand on our mental health services at the moment, which we expect to see actually after the Christmas period. The system, we're already having conversations in January about the impact of those winter plans, particularly across the acute providers. You'll remember, and we still are monitoring those urgent and emergency care metrics really closely across our ICB. So again, those ambulance handover times, the waits in emergency departments, etc. Those metrics are still not where we would want them to be as a system. But they probably are slightly better overall at this stage than perhaps they were last year. The acute hospitals still have seen very high prevalence of winter viruses. IPC arrangements have meant over the last couple of weeks that quite large numbers of beds have been closed to admissions. So again, we're not out of the woods yet. But early indicators are certainly the plans have probably been more robust this year. So it'll be interesting to see what happens. We've come back from the Christmas period. There is some issues with discharge from acute hospitals at the moment, causing that lack of bed availability. It's in the press today and has been over the last week or two, that prevalence of what's called corridor care by the acute hospitals as well. And we have seen some of that across our system as well. So we are working very collaboratively together. I was at 2 urgent emergency care boards yesterday, where we already start to just sense check those plans, anything more that we can do as a system to continue to reduce the impact on service users and patients of winter as well. So broadly, that's where we are at the moment. Very happy to pick up any questions around that. And then we will, at the end of the winter period, start a full detailed review of our own winter plan and also obviously the winter plans across the system.
Okay, thank you very much, Michelle and Lynn. Obviously, we've got Pete with the finance report later. Tim.
Well, 2 questions, one to Michelle, well, not so much questions as comments, and one to Lynn. Michelle, I think congratulations are due to the plans you've done this year. A real effort gone into not only the flu programme, which I'll come back to in a moment, but also the National Staff Survey. I mean, I think both of them has been a lot more work and pushing the staff to complete the survey and also to take up the flu vaccine. And I think both shown in the figures that you've provided. So I think congratulations are due to the executive team for developing this programme and the staff survey. So there's that. But on the flu side, you may remember at the last COG I raised about a query which Dean answered to some extent about why we couldn't get staff to take the flu and have the flu jab and everything else. And I mean, I've been wondering what it is that prevents staff from taking up the offer of flu vaccine. A couple of days ago, I saw that there was a big survey that had been undertaken by Imperial College London, which was published in the Lancet, about why people didn't take up vaccinations. Apparently for men it's because they think they're going to be so fit and well that they don't need vaccine, and for women it is because they're concerned about effect on the possibility of fertility and so on. And it occurred to me that would it not be possible for us as a trust to conduct our own survey of staff as to why they don't take up the offer of a flu vaccine? Because I think it could inform next year's programme for the flu vaccine take-up, because even though it's much better than it has been and with a lot of work done, nevertheless it's still way below what you really like. And it has an impact on sickness rates, and that has impacts on staffing and so on. So I just wondered, but that was my first question.
Well, first of all, thank you, Tim, in relation to the well done exercise. It's a team effort, so I will pass that back. We always do it as a team, so thank you for noticing that. It is sincerely appreciated. We did do a short survey in relationship to staff and one of the reasons why they don't uptake of the vaccinations, and there was a couple. There was one, they're fit and well, they don't need it, they'll be fine without. The second one was that they're scared of injections and they don't fancy the injection. The other, if I remember rightly, was time. They didn't necessarily feel that they got the time to do that. And there was still a few that said they thought that either the side effects from a fertility point of view, or that people could get other things as side effects, etc. So that's why I think one of the reasons why our uptake is a bit higher this year, because we concentrated on those. We did all sorts of things in relationship to people that have these phobias with needles. We put couches in so people could lay down and have them, and everything else. So we did quite a lot. What we agreed with the exec team on Tuesday was that we'll do even more detail, because that was a bit of a snapshot before we started the programme in October. And we do the same for the staff survey, where people don't fill in the staff survey. So we decided we'd do we'll start with flu, but we'll do a bit of a bigger deep dive into building on the Lancet study, which was quite interesting, to know why they actually don't, and start with some of those reasons. So when we've done that, we can share that with you and the governors, because that will be interesting and formulate some of our plans. The other thing, if you remember, is we do link in the flu vaccination with an extra annual leaves day. So we do that if their appraisal is up to date, if their statutory mandatory training is up to date, and they've had the flu vaccination. We did put the COVID in, but obviously we've moved the COVID vaccination now. So we also, when we do the work in relationship to come and get your flu vaccine, it is linked to that, and we have a lot more processes now to ensure that when we are giving out, because the question from the governors will come, it'll be a good question, it'll be the right question, is how are you ensuring that you're giving the right people the right annual leave day? So we've got a really robust method now that we don't give people that extra annual leave day if they've not had those particular elements. But it's a really great question, Tim. Personally, I think we should link it to validation from a statutory point of view, but we can't do that. But I'm glad to see that, you know, the numbers are growing all the time, and we're being hopscotch, whether we're 2 or 3 or 1 or whatever, we're just having a hopscotch. But my determination is to try and get higher than Harrogate at the moment, and we're so close. But thank you for those comments, and I will take them back.
Thank you for that. Can I turn to Lynn then, please?
Yes, go ahead, Tim.
And it is to do with another topic I raised, which is about neurodiversity. And on page 6 of the Chief Exec's report, we've got the about the ICB, and it says that we've been asking, after all, and I've been raising this for some time, about the negotiations with the ICB, trying to get more funding and everything, and the last minute said there'd be an update, and I'm assuming this is the update. And what they seem to be saying is that any proposal that we put forward cannot cost more than the current projected outturn. Does that mean, therefore, that they're saying there's going to be no extra funding?
Shall I pick that up? Yeah. So it's still under discussion, unfortunately, Tim. I think we are getting increasingly closer, it feels like it, to a solution. And some of us were talking to Theresa Fenwick on Friday about this, amongst other issues. So what we know that they are doing, I've raised it here before, is we're funded to a degree, but obviously because of the waiting list, the ICB are funding diagnosis within the independent sector, and that's obviously costing the ICB significant amounts of money as well. So what we're talking about is, if you take that funding into account, and it was through a different operating model and clinical model for, you know, actually it's that totality that we believe actually we could use that much more productively. So that's the whole position, Tim. I hope that makes sense.
Yeah, I'm with you now. I see. It's the total pot's going to be the same, but we hope to get a bigger share of it.
Yes, and that by doing that, obviously we will spend that money in a very different way. As well, to the better and reduce waiting times.
Yeah, I mean, nevertheless, the figures are pretty horrendous, aren't they? I mean, I know it's a national problem, but I mean, the figures are just quite substantial, aren't they? I think Tony was raising something about that at our pre-meeting, and Tony's got his hand up, I see. Thanks.
Thank you, Tim, and Lynn. Tony.
Yeah, just picking up from what Tim said, is that when I looked at the performance figures, if I've got this right, paediatric ASD 1700 waiting 52 weeks, and peds ADHD 900. I think our concern as governors is that a lot of these children won't be seen, that they'll end up being transferred into adult services and onto an adult waiting list. The way it's going, looking at the length of some of these waiting lists, and they're continuing to grow, of course. So it is a real concern to us in terms of what's happening here.
Michelle, do you want to come back on that?
Yeah, no, I would just say that it's a concern to all of us, Tony, to be honest. And in fact, I mentioned it as the ICB board meeting itself yesterday. Being an ICB board member, that we've got to get some solutions to this. We've offered some solutions as organisations. As I said, we are making some progress now, but I'm hoping that we'll be able to bring a resolution to the governors and the board quite soon, hopefully, because nobody is happy about it, Tony. And we have been working quite hard over the last to maintain what we're doing and to streamline, as you've heard today, with our flow and how we actually maximise our capacity as well. But you know, you're absolutely right. It's not suitable position anybody wants to be in. But I did raise it yesterday at the ICB board.
Thank you.
Thank you. Thanks, Michelle, for that update. Brian.
Yes, thank you. Following on from that, really, on page 10 of your Michelle's report, she talks about the Do-It profiler for the neurodevelopmental services. And I'm just wondering, not now, but at some time in the future, would we be able to have some more information about that? Perhaps one of the training sessions to see how that works. And following on from that, are you able to indicate whether that's going to have any impact on waiting lists and waiting times? Is that going to be a part of a solution for the excessive waiting times?
But basically, yes, but I'll pass over to Lynn, yeah.
Yes, it's been used in North Yorkshire actually, which had the highest waiting times across the ICB, and they have seen reduction in the waiting times. Actually, we've improved this tool as well ourselves. So it's very much part of the overall model. It's a digital triage tool. So, and what it does do, as the description hopefully says, is really offer families and young people and professionals support very early on, so that actually some of those folk will not need to move on to diagnosis if we put the early support in there. So the same principle that Justine was talking about earlier, inverting those triangles to put more prevention in, because obviously our waiting list is in its entirety for diagnosis. So we really want to switch that model around: early support, early intervention, and then, you know, you don't need a formal diagnosis per se if you get that support irrespective.
Thanks for that, Lynn. So I'll take that suggestion away, Brian. It might be quite useful to, I'll think about this with colleagues, maybe package up some of the most innovative digital tools we're either are deploying or seeking to deploy in one of those sessions, and this profiler could be part of that, if that's helpful. Tony.
Just moving on to another issue is, Michelle, you mentioned about sickness, and obviously Tim picked up about the vaccination program, which is good news. I've been looking at the safer staffing figures, and bear in mind that this report, I think, is from September. And if we look at, I've looked at Hull East mental health team. According to this, it's got a sickness rate of 24%. Now, this was at the start of the vaccination program, or not long after it. And if I've got this right, also West Hull had a vacancy rate of 15%.
Are we on the performance report here?
Sorry, I'm just linking it to performance report.
Okay,
I thought I'd just bring this in now, linked to the discussion we've had about about sickness. And I see the vacancy rates are quite high as well. I think East Hull is something like 41%. My sense is that looking at this is that there's obviously something else happening here, and just wondering, what plans are in place, because it looks like some of these sickness rates aren't related to, the flu virus, possibly.
Well, they're not. I mean, at that particular time, they weren't really started with the flu vaccine, the flu pandemic. We've got general high levels of sickness across the organisation in hotspots. Right. We're no different, and we're not an outlier. And our overall sickness level for the organisation is on par with our other colleagues as well. To be honest, our other benchmark organisations, which is why we talked about before. We've done quite a lot of concerted work on health and wellbeing. In fact, we've just got the Humber unbelievable wellness for 2026. Yes, there are various other factors in relation to that, but we've just received a safer staffing report from the exec management team, which shows an improved picture across all those metrics, and more importantly, our care per patient per day is still high and is still an outlier. So irrespective of the pressures that staff are under, we're still producing a safe service, because we do triangulate it. Sure. So we do provide a safe service, and we do provide a higher than a benchmark care per person per day. But the board will receive the full updated 6 monthly safer staffing in detail at the next, and that'll obviously go onto our website, so you can have a look at that when it comes out. But we've just seen it on, and things have improved. We've still got some areas, Tony, that we need to get better at, but we are in an improved position. But there were several other factors in relationship to the ones that you've pointed out.
Okay, thank you.
Thanks for that question, Tony. I don't think I can see any other hands up. So can I suggest it's 15:08, we take a 5-minute break and be back at 15:13 to carry on with the agenda. Thank you very much.
Perfect, thank you.
Okay, welcome back everybody after that quick break, and we'll continue with item number 9 on the agenda, and it's around the Associate Non-Executive Director programme. I promised I'd come back to Council of Governors with a paper on terms of how we might move forward. You'll see from the paper that we've had discussions at the Appointments, Terms and Conditions Committee about this, and basically I think the ATC, along with the board who I've discussed it with as well, agree that we should continue with the programme, and I think look to recruit one associate non-executive director this forthcoming year. But I think everything pretty much staying the same, but with just the additional sort of reach out really to see how we might link in with particularly, not necessarily exclusively, the other NHS trusts in our area who have similar programmes, so that we can, maybe look at ways in which we can, enable our associate non-executive directors to meet with those other associate non-executive directors, and whether we can see some different ways we can create a bigger pipeline of opportunities, I suppose, for people if they want to proceed with trying to become a non-executive director. And I've sort of highlighted in the paper, and this is based on obviously discussions we've had at the Appointments, Terms and Conditions Committee about some of the, the things around timing, around competition and all of this sort of thing that hasn't necessarily in our case meant that associate has been successful in being recruited. Having said that, I think all 3 of the associate non-executive directors we've had so far have all felt they benefited from the experience, and I think that's really what they'll take that with them to whatever else they do, some of which involves continuing work in the health service or the voluntary sector in one form or another. So I won't say any more. Happy to take any questions. I hope I've reflected the discussions we've had before in the paper, and I'd welcome your approval for the recommendations. Any questions or comments? Okay, no. Can we go straight to a vote of agreement with the recommendations? Is the Council of Governors happy to approve the recommendations? Brilliant. Thank you. Thank you so much. Okay, then we'll now move on with that being done to the non-executive directors assurance reports. And first up, bear with me, we have Keith, but he has recorded something and is happy if there are any questions for them to be passed on for him to get back to governors individually. Have we got that recording ready, please? Board support unit. Thank you. I can't hear that. Can anybody else hear it?
Good afternoon. I'm really sorry I can't be with you at Council of Governors today. My apologies. I am travelling in France today and I was a little bit concerned about my ability to get a live link. So apologies for my recorded message instead. So I'm here today to update around the Finance Committee Assurance Report for the meeting which occurred on the 26th of November 2025. Several key areas, I think, real positive assurance around the new format for the committee moving forward. And this came from a review of the agenda and looking at providing a continued focus on grip and control and making sure that we have the right financial processes and measures in place, which is really important. But perhaps the most important thing, I think, is the second section, which is a new section, which is to really talk around efficiency and productivity and really focus on how we're spending our money and making sure that we're spending our money as wisely as we can for every pound that we get. And then a third section talking around other aspects like digital contracts and other things that are relevant to the Finance Committee. And this was the first committee that we tried that 3-section meeting with, and I think it was really good in terms of the topics that we covered and in terms of the real focus we've got now on efficiency and productivity. So positive assurances around the discussion is starting to gain momentum around productivity and efficiency. I think there's more work to be done around working through what metrics we look at, making sure that those metrics are the right metrics and we've got the right width. So we've started a little bit broader than we need. And I think over time we can slightly narrow down and focus on making sure that we're talking about the right things. But really positive progress to update the committee on around agency and bank usage in the hospital, with agency spend down now 55% over the last 2 years and bank is down 9%. More work to be done. NHS England's targets, as you know, are looking to drive that further, but we've certainly done the work on agency, but I think the bank target will be a challenge for us. We've tasked some areas of work around overall savings in time and money relating to primary care services leaving the organisation, and that's a piece of work that we need to look at. Also looking furthermore in the digital work that we look at to make sure that we include really strong business cases, both for the deployment of the digital, but also for the evaluation of the savings or efficiencies that we then get for that. And that talks slightly to the efficiency and productivity piece. And also looking now at a 3-year cash flow and CapEx spending view, which is a requirement now for NHS England, but a real positive, I think, for the Trust in terms of making sure that we're looking far enough ahead and being aware of the changes we make now and the implications that has. So we're in a really strong financial position, re 25-26, and we're projecting to achieve our agreed budget, which is really important. The system is struggling, obviously the wider system, and there are implications for that for the wider system. But most importantly, from a Humber point of view, we are where we need to be and we will achieve our budget, which is really important. We looked at several areas in the productivity and efficiency around productivity update, comparing ourselves with benchmarks like the model hospital to make sure that we're delivering our services in the way, national cost collection, still some work to do around that, and around making it specific for mental health and making sure that we're able to see the right things. Really positive update on digital productivity. And looking at efficiency gains for the digital delivery and deployment. We're doing more work to be done there, but a real positive, I think, in giving digital a bit more of a focus in the committee, which is important. And then we have the usual updates around partnership and strategies. The annual non-safety clinical report was ratified by the Finance Committee for the board. Other than that, no real areas of concern. More work to be done, and the next Finance Committee meeting is in fact next week. So I will, I'm sure, be reporting back to the Council of Governors at some point. Sorry, I'm not here to take questions, but I'm very happy if anyone has got any questions, if perhaps Caroline could make a note of those, and I will happily answer those remotely. Hope you have a good meeting and look forward to seeing you all soon, and my apologies again for not being with you today.
Okay, thank you. And clear the screen for that and get back. Okay, thank you. Are there any questions that governments would like to raise now that we can make sure you get a response to? I can't see any hands. Okay, fine. Okay, if you do think of something, please let the board support unit know. Okay, Dean's report is in front of you as well. Are there any questions? We've touched on a few actually workforce issues already today, haven't we? Are there any other issues within Dean's report you'd like to get a question responded to? Brian.
Yes, it's, again, this is not something that I expect to be answered at this meeting, but I would be interested in these health MOTs. It'd be interesting to have some sort of session on what they consist of. So are they physical checks, or do they include psychometric instruments or whatever? And how are staff encouraged to attend them, and how the effectiveness of them is measured. So it's just another suggestion really for another meeting, I guess.
Yeah. No, thank you. It's an important one. I have to, you know, at board we've discussed it as well, about, you know, it seems to be for people who take them are useful, but also we're quite interested in how you align who is actually taking the opportunity to have these, and how that matches against the people who are, you know, off sick, and what we can do to support them. So understanding, a bit like some of the other questions governors have raised today, understanding a little bit more about which staff are taking up, and if they're not and they really may benefit from it, why not? So yeah, happy to take that away, Brian. We might be able to send you some just some information in the interim, not too long, just giving you the basic outline of them and a few numbers if that's helpful for all governors as well, just as a sort of info note. But I'll take that away. Thank you.
Thank you.
Any other questions on the people and workforce? Tim. Tim, you're on mute.
Sorry, sorry, I'm a bit unclear. Are we saying any questions on agenda item 10?
10B.
Oh,
10B.
only 10B.
I'm going to go
No,
through each of them.
I've
This
got
is
something
Dean's
on
report.
10D. Sorry.
No, sorry about that. No, just if there's anything to take away to get back from Dean, that's fine. Okay, I can't see any more, and we move on to, let me just, get my order right here, to Steph on Mental Health Legislation Committee. Steph. And I think, Steph,
Thanks.
you're having a bit of a problem with your, are you still having
I'm
a problem
back.
with your screen? You're back, right?
Yeah. My camera wasn't working. I've managed to fix it. Good afternoon, everyone. For those of you who don't know me, my name's Steph Cool. I'm one of the non-exec directors, and I chair the Mental Health Legislation Committee. Our last meeting was on the 6th of November. We'll shortly have another one at the beginning of February. And nothing major to report to you. In terms of performance, everything was within control limits as expected. Use of force, I just want to highlight the really good performance on reducing restrictive interventions and use of force. The use of restraint, including rapid tranquilisation, continues to reduce, and it's its lowest level for 2 years, which is the result of really hard work by the teams in all our inpatient facilities. Continued focus on compliance with seclusion reviews. Seclusions are also within control limits, and really good work around co-production with service users as well by the reducing restrictive intervention team. As ever, we receive case study reports where it's useful. We had one really good one this time on Section 17 leave and how valuable that is to the patient concerned. I said during my report, and certainly at the last meeting, we had no further update on the Mental Health Act. It's now passed through its parliamentary stages and achieved royal assent on the 18th of December 2025. It's referred to as the Mental Health Act 2025 now. It's not really a new act, it's amending previous legislation as we know. So that has received royal assent, and therefore the question is what now happens? Well, nothing major is going to happen in the next few months. Nationally, the NHS England will set up a group which will look at developing a code of practice, which will be ready, I hear, by the end of 2026 or beginning of 27. And there may well be some secondary legislation around that, and there'll also be quite significant training requirements that come at that point. I don't want to dwell too much on this at the moment, because obviously it's going to be something that's going to be unfolding over the next few months and several years. And it appears that the timetable for implementation of all the parts of the Act will be over potentially up to a 10-year period. So there's quite a lot of parts to it, quite a lot of pieces of work to do, but it's something that we'll continue to receive updates at the board, and it's something that we'll keep an eye on as the committee as well. At our last meeting, we looked at, as we do on a regular basis, the multi-agency public protection arrangements. And we received a really interesting case study around MAPA and how that can help to protect the public, and how it can help also to support offenders who are also patients of ours. That's all I want to highlight today. If anybody has any questions, I'm really happy to take them.
Great. Thanks very much, Stefan. And Dr. Kwame Fofi, our medical director, which Steph is also aware of, is working up a sort of, if you like, a sort of plan of action on the Mental Health Act as it's 2025. I think reporting back to the EMT, I think, isn't it, Michelle? And it will come back to board in terms of what some short-term, medium-term, long-term actions we'll need to take. But yeah, I think you went to a webinar, didn't you, this week on that, Steph?
I did indeed, and there's quite a lot of detail. There is a really good briefing document produced by NHS Confederation on this, if anybody's interested. I'm sure we could send that round to governors. It's just a couple of pages that highlight the various sections and what needs to happen. But there's a lot to work through with this, and yeah, we're going to get an update from the medical director at the next board. So
great, thanks very much, Steph. Any questions, comments? No. Move on to Stuart, Collaborative Committee.
Thanks very much. Good afternoon, everyone. Nice to see you all again. My report is from a meeting way back in October, the 13th of October. And I'm going to pick out just 3 or 4 strands of highlights for you. The financial position of the collaborative arrangement is looking good. And you'll see reference to some work going on to see if there's some scope for investment or reinvestment in services from some of the funds that could be recycled, which is always pleasing to see. There's good evidence still of the benefits of finding alternatives to admission. I think in the earlier presentation from Justine and colleagues, we heard mention of the EDIT service. So that's kind of early intervention into eating disorders. That work is now being replicated across all age groups, which is proving effective in terms of both treatment and use of resources. And I would say, we spent a bit of time on this at the last meeting, there's really good evidence of the, if you like, the spirit of collaboration amongst the partners in the collaborative, which is very good to hear. So both the formal mechanisms and the partnership arrangements are holding up well across all 3 work streams. We did have a meeting in late December, which hasn't yet reported to the board. There's no new issues to report to you on that. That will come to you in due course. But I'm just going to add a little footnote about the Schön Clinic. So at the point of this October meeting, the Schön Clinic had announced it wanted to close, and work was in hand to ensure that all the patients in there were being properly conveyed to somewhere else. At the December report, we heard that had been completed. And so that process by which the Schön Clinic has essentially left the collaborative and all the patients have been transferred to appropriate settings is now complete. I just want to add that in as a footnote to you, for you. Otherwise, nothing new to report. And I'll open up for any questions.
Thanks very much, Stuart. Any comments or questions to Stuart? Tim?
Yeah, it comes, in fact, the last point that was just mentioned by Stuart about the Schön Clinic. I mean, patients being transferred to alternative care provision. Where is that generally? Because I see something on the next page about Rarian Fields. I've never heard of that one, I must admit. And I mean, again, we're talking about out of area, are we? Can you help me with those things?
Yeah, let me. So I'm now looking at a note. You haven't got it, but this is a note we received at our last meeting on the closure of Schön Clinic. So what I'm being told is that all patients were safely discharged or transferred in line with their clinical plans. I don't have the details of the specific locations of those individuals. What I can say is that the Rarian Clinic is part of our collaborative arrangement, so it's within the geography of our collaboration. And generally, the number of patients who are out of area across the collaborative remains quite low. So my understanding is that the closure of the Schön Clinic didn't exacerbate our out of area position, but I'm not close enough to the details of every individual case. So if you want,
no.
we can provide some
No,
further
no.
information
I
outside the
wouldn't want to
meeting.
know that. It's just generally the sort of out of area placements, and often the nature of the disorder is such that, you know, they're taken right. If they're way out of our area, such as Lancashire or somewhere like that, it's rather difficult for relatives to maintain contact. That was my concern.
Yeah.
But can you then, on the next page, we're talking about adult eating disorder, which again it follows on from what you've just been saying. But I was fascinated by the fact about work progressing in North East Links. Can you clarify that? Because, I mean, Navigo covers North East Links. Do we cover as a trust for adult eating disorder, and Navigo doesn't do that, or what?
Again, Tim, I'm going to have to come. I'm not close enough to the operational detail on that one.
Don't worry. Don't worry.
Shall we pass over to Lynn?
Michelle.
Sorry,
Yes, please.
pass over to Lynn for the provision, because yes,
Yes.
Navigo provide inpatient services within that, which is what we're talking about. We do some, but we as a providers, we tend to work it collectively together as we do things like perinatal. But Lynn, do you want to just clarify the position? And all patients were transferred successfully without increasing the out of area provision.
That's
Tim,
right.
and I think you're absolutely right. We don't go into individual patients,
Yeah.
which is what you agreed. So that's absolutely fine. Lynn, do you want to just give us a bit of an update on eating disorders?
Yes, so Rarian is the service provided by Navigo, and it is the adult inpatient service. And as I understand it, most of the patients were actually discharged because there was a bit of notice period before the closure, so at the Shern Clinic, and any that needed a bed did go to the Navigo provision. So in area, as far as the Commission's services goes. So, but adult community services, obviously, Tim, are provided very differently across the patch as well. In fact, the adult eating disorder service for Hull and East Riding is provided by Community Healthcare Partnership, CHCP, as well. So, however, as well as there is work now, as has happened with the children's service and the EDIT team, the out of hospital service, that's been really successful at reducing admissions. The same work is happening across the adult eating disorder pathway to look at how we introduce that very type of community provision that we've got for children, because the evidence base for that is really high as well. So that's where the focus is now, on the adult eating disorder pathway. But there still is local provision commissioned locally for each of the 6 places. It's a bit different, Tim. In fact, East Riding has very little commissioned capacity for adult eating disorders. That's been looked at as well.
Right, thank you for the information.
Does that help?
Yeah.
Yes,
And
it
Pete's
does, thank
just put something in chat box to say Rarian is based in Grimsby, which is in the collab footprint, and we've presumably through the collaborative increased capacity to deal with flow and demand. So again, you know, it's a good example of the collaborative working that's been happening with all our partners.
Yes, thank you.
Isabel.
Hi, yes, thanks, Stuart, and all the best, because I don't think we're going to see you again. Just under the adult secure work stream, I just wanted to ask about the HOPES funding for patients with learning disability and autism and what that project involved, please.
You're referring to the yeah. So this is the last bullet point of page 5 of the report. Yeah.
Yeah.
So that is essentially some work in progress to try and support people with learning disabilities in hospital and segregation. If you want more details of that, I'll need to get back to you because as I say, I don't keep close to all the operational details of all the work streams. Do you want me to do that for you?
Lynn's
No,
got
we
it.
got
Lynn's
Lynn, sorry,
waving, so she might-
can we go to Lynn, because we can give you a bit of an update
Thank
now.
you.
Yeah.
Lynn.
Thanks.
Yeah, you're very correct, Stuart. That obviously this model was born out of work around learning disabilities, as Stuart says, was provided not just secure services, but all inpatient learning disability services, originated from services on the West Coast in Liverpool and the Wirral. And obviously what we're doing around the secure funding is it's time limited at the moment, but what we're utilising the resource to do is skill up our staff in that hopes recovery model, which has proved very effective in reducing the use of segregation, as Stuart said, and hastening people's discharge from hospital in the right way. So, but we think a lot of our staff have some of those skills already, but with this additional funding, we'll augment those skills over the next 12 months. And then there'll be a review again about what happens in the future. But I think that sort of developmental approach around skilling up staff is absolutely the right way forward. And that's what we've supported through the secure work stream. We're evaluating it as well. So there will be further information down the line.
Lovely. Thank you.
Thanks, Isabel, for that. Thank you. I can't see any other hands up. So thank you, Stuart, for your last assurance report to the Council of Governors. And yeah, we'll miss you, but we also have Kath. Take care. Right. Okay. I think on the front page, by the way, just so I haven't missed something, it did say about Phil having a quality committee, but that's not correct. I think that's an error. Can we get sort of make, isn't it, board support unit?
It is an error. It is an error because the quality committee was late.
I didn't want to feel I was leaving you out there.
Oh, no, don't worry.
Okay. Right then, in that case, we'll move on to item 11, which is the Council of Governors Subgroups Feedback, Appointments, Terms and Conditions Committee, and Tony, Chair of Engagement with Members Group, if there's anything you want to share. Over to you two. Marilyn?
I haven't really got anything else to bring up apart from the piece that you actually were given. I would like to say that we did have a really good discussion about this. It was my first sort of meeting back, so I was quite pleased that there was nothing too difficult to look at. Yeah, I mean, the only thing I would say is that it was really quite sad that we were talking about interviews to replace Stuart, because I just sent him a message saying that I felt he was, I don't know, since I joined, he's been very helpful. Let's say that, and I wish him well for the future. So we were talking about replacing him, so that was quite sad. I think apart from that, the rest is as is written down here. I mean, the group was asked to approve the appointment of Catherine Smart, and that we did. And we had a review of the non-exec and chair cost of pay, living pay increase, which took place, which was agreed by the group. So that's about all that we had on the last meeting.
Okay. Any questions to Marilyn? Could I just, to the board support unit, for the forthcoming interview process, and I know Tony and Marilyn have discussed this, Marilyn has got the dates in with the diary. She will be on the panel with, I think, Isabel, and Tony, I think you volunteered to be on the stakeholder panel from Governors. So can we just, Marilyn's already got the dates in her diary, so can we just correct that and make sure that that's the Governor representation going forward? Thank you. Okay, Tony, anything from you on engaging members?
We had the engaging with members meeting yesterday. We discussed the fact that with Simon resigning as a governor, because the election cycle in effect is that Whitby and Rydell will be lacking a public governor for something like 9 months. So what we've suggested and agreed is that although Tim doesn't not represent that area, he's going to act as a contact point for members in the coming months, which we're grateful for. So we have got some link and the governor overseeing that, if I put in those terms. Other key elements is that obviously our continuous discussion about the annual members meeting going forward. We are looking to see what we can do to align governors more closer to the various groups. For example, the public and care experience groups patient and case care experience groups, etc. And we're also doing some further work on about how we communicate with members through contact details and personalised emails, so governors can use those. So they're the main points, really. Thank you.
Great. Thank you very much for that. That sounds like a good idea. Thank you, Tim, for taking that on as well. Any questions to Tony? Comments? No. Okay. Thank you both, Tony and Marilyn. And we'll move on to performance update. Pete.
Thanks, Caroline. So the link to the most recent performance report that went to the board is in the paper. I guess it's a very similar pattern of performance to what we've seen previously at Council of Governors. Continue to see strong performance on a lot of our workforce metrics, and we continue to include comparative data because that's what the governors have requested in this report. Sickness absence continues to be an area of focus, and you can see from the paper and the board report that we do have some targeted series of interventions taking place, and that's updated to ODG, EMT and People Committee. And we do have plans for out of area, but obviously we are in the planning round at the moment, so those plans are still being discussed and negotiated with the ICB. But if they come to fruition, we know that that will significantly improve the out of area position for the ICB. You know, I'm conscious of time, Caroline, so that was a whistle-stop tour, but happy to go straight to questions.
Okay, thank you very much. Any questions or comments, Tim?
Just quickly, Pete, the out of area placements, the PICU, when you say a solution for the PICU beds, do you mean the female, or are you saying about male? Because I know there's the capital funding, wasn't that for the female PICU?
It was both, Tim. So there's 1.8 million of capital that will create a 5-bedded HDU unit for females, which will stop females going out of area, or should stop most females going out of area, and it will increase the capacity for male at Avondale.
At Avondale?
Well, PICU.
Yeah, PICU, yeah.
Yeah, right. Miranda. Call it Miranda.
Okay, yeah. Thanks a lot.
No worries.
Okay, thanks, Pete, for clarifying that. Any other questions to Pete? No. Okay, we'll move on to the finance. We did have obviously quite a lot of questions around performance earlier on today in the meeting. Finance report, Pete.
Yep, again, thanks, Caroline. So this paper takes us to the end of October, which is the last finance position we took to public board. You know, I've included in the paper the system financial position because I do think it's important for governors to understand the context of the system, and the system is running incredibly hot on finance at the moment, and it'll probably come out in the next week or so. But at month 9, providers will be asked to lock in their forecast outturn position, and we highly expect the acute providers across Humber and North Yorkshire to declare that they're going to not deliver their financial position this year, and the numbers will be quite significant. But I'll probably send a note around when we know that, Caroline. I can't say that today. You know, as a trust, we continue to record a favourable position year to date, and we know that's down to the treatment of non-recurrent income. And you can see from the forecast, we have a high level of confidence we will hit our break-even position or better this year. Cash remains quite comfortable for us at 19 million, and we also continue to have really strong performance on the better payment practice code, which, you know, was quite important for us a couple of years ago. There was a big diktat from centrally. So again, that was very quick, but I am conscious of time, but happy to take any questions.
Thank you very much, Pete. Any questions to Pete? No? Okay, thank you very much indeed. That is the last agenda item for today. I've not been notified of any other business, and therefore thank you. A review of the meeting. Thank you for all your questions and comments today and engagement. I think, you know, my sense is that was a really good start to 2026. So thank you, all of you, for that. Anything anybody else would like to comment around any of the items under that under the review of meeting that we like participants to consider? No? Happy with? Yep. Stuart.
Well, I just want to say farewell to everyone and to wish you all the very best in your important work. And it's been a real pleasure to work alongside you and support you and answer your questions. So good luck, everyone, and thank you.
Thanks very much. Thanks very much, Stuart. I've got Pete, Michelle and Marilyn. Pete.
Is it worth just a very, very quick update on planning, Caroline. You
Okay.
mentioned it earlier. Yeah,
Okay.
so very quickly, because I'm conscious of time, we submitted our first plan on the 17th of December. It was a 2-year plan. In terms of the key components of the plan, in terms of activity, as a trust, we're meeting all activity performance targets, with the exception of perinatal mental health, where we hit 8.6% rather than the 10% national target. And that is because we're commissioned to deliver 8.6%. So we've never been fully funded to hit the national target. In terms of workforce, we've got a small bit of workforce growth in our plan at the moment, but that's for the PQ scheme, mental health support teams, and the scheme we heard about earlier at Inspire. So again, all fully funded, so there's no unfunded growth in our plan. The big number at the moment and the focus with the region and the ICB is the finance submission. So our first plan was a 3.2 million deficit plan, you know, and that's starting from the update I've just given, which was a strong financial position. And there are 4 things that are driving that financial deficit. So very quickly, the Older People's Out of Area scheme, which started 18 months ago, we still haven't had the recurrent funding for that. So that is a query we've got with the ICB, and I'm picking that up later. Sorry, my phone's just going, apologies. We have a difference of opinion on growth. Planning guidance recommends 2% growth. We've been offered 1%, so we're arguing we need 2% growth as a trust. And there are a couple of technical adjustments in there that add up to about £500,000 that we are just discussing with the ICB at the moment. So I think that's a whistle-stop tour. I think we're in a really strong position. I mean, you've been to the regional meetings. I don't think they've got anything that can really throw at us in terms of our plan not being robust, strong, defendable. I'll stop there. Don't know if you want to add anything, Michelle.
Michelle?
No, I'm just conscious, obviously, from a position that we're in at the moment, at the public meeting, etc. But I think that's a really good outline position. The meeting on Monday went well, and we'll just give you more information as we got it. I alluded to earlier on that we're having weekly submissions on the 2-year and 3-year plan. We're triangulating it with workforce as well as activity. So they're the main headlines. So no, that's
Okay.
fine, Pete.
Thanks very much. Could we just, because we sort of slightly got out of the agenda thing, could we put that last piece from Pete to sort of, for the minutes, whatever you're going to put in the minutes, under the sort of maybe the finance report or something, so it can go under that, so it's, you know, it doesn't look odd out on its own. But yes, and as a board, we spent, you know, a lot of our time at our last strategic meeting in December together working through our plan and for the first submission, so deadline, but there'll be more on that when we get after the second deadline that all the trusts have to meet. Okay, so I hope that you found the meeting interesting. I hope you felt the papers helpful. Is that the case? Can you give me a thumbs up, everyone, or don't give me a thumbs down? It's only the start of the year. No, whatever you want to put up, that'd be great. Thank you very much indeed, everybody, and we're just about on time, 3 minutes over. I don't think that's too bad at all. I will see hopefully some of you at the governor briefing at the end of this month, and some other events in the next 3 months before our next meeting. Thanks very much, everybody. Have a great rest of the week.